This week on the BackTable podcast.
So we're actually collaborating with Mako and onboarding them with tympanometry. We're teaching them how to do it. Our audiologist is helping. And then we're giving them this antibiotic stewardship program. And we're doing a research project right now in Denver showing, did this change your diagnoses? Did this patient get an antibiotic? I mean, I think we all know what's going to happen with that. It's like, this is so cool because, again, not a big ask. I mean, it's actually revenue generating. Like each tympanometer is going to equal about 20 to 25K a year per provider. It's going to give them confidence to say, actually, this isn't an infection. I know you're having ear pain, but if we teach them about TMD, this type A tip shows that you don't have any fluid. So that's going to increase patient satisfaction, not getting an antibiotic, because they might be upset not getting an antibiotic, but we're actually giving them the right diagnosis.
Hi, everybody. Welcome to the BackTable ENT podcast. We're a podcast that focuses on all things otolaryngology, and we've got a really great show for you today. Thanks for stopping by.
We're so excited. I think we have an awesome guest and a great topic today. It's on education. We have Dr. Jeffrey LaCour. He's an otolaryngologist practicing in Hammond, Louisiana. He's also the founder of Compassio Medical Education, which provides online courses for primary care specialists and advanced practice providers. Jeff is here today to talk to us about ENT education for our APPs, nurse practitioners, and other healthcare providers in our communities. Welcome to the show, Jeff. How are you?
I'm doing great. How are y'all doing today?
We're good. So nice to have you on.
Thanks for having me.
This is going to be a great combo. As you know, we like to start the show just giving you a chance to tell us and our listeners a little bit about yourself and your practice.
Yeah, sure. So I live in Louisiana. I went to LSU for med school, LSU for residency, and then Katrina hit, and I ended up at UNC Chapel Hill. And so it was a blessing to have Dan Nuss, Rick Pillsbury, and all that crew. I'm the father of 7. I just had a new
Wow.
6-week-old baby, my wife and I.
Congratulations.
So yes, thank you. I'm officially a very old dad. I was already an old dad, but I'm really old now. And so they were doing the math. They're like, when your daughter graduates from high school, you're going to be 65. I was like, thanks a lot. That was my kids saying that. So,
well, they're good at math, so.
Yes. So it's been awesome. And then, so I did a fellowship in otology, just a 1-year fellowship at Pittsburgh year, and then a fellowship in rhinology under Fred Kuhn. And then I've been in Hammond ever since. So I've been practicing for 15 years. I love it. Yeah, I focus primarily on surgical and rhinology. And so, yeah.
Awesome. So talk to us about Compassio. Compassio?
Compassio. You can say it however. It's basically Latin to walk with or to suffer with, because let's face it, a lot of education and residency is suffering.
I love it.
So we're there to help you suffer, right? To help walk with you, right? We don't call it suffering, but to walk with you, right? I would say back in 2019, before COVID, we all know as ENTs, we see patients coming from urgent cares, ERs, being diagnosed with acute otitis media or serious otitis media when they never had an ear infection in the first place, right? We kind of have a running joke in our practice. We come out, we're like, hey, guess what? I've got another adult with acute otitis media. And so it's kind of a running joke, haha. But it was kind of like, you know what? Let's do something about it, right? So what I started doing in 2019 was I started collecting videos and images using my cystoscope in the ear with the hopes of creating an ENT course for urgent care, ER, primary care, pediatric providers, right? And I wanted to focus on APPs, NPs, and PAs, honestly, because I thought they would be more open to being told you're not doing things correct, honestly. And so I was like, well, let's start there. So I started doing ears first, and then I started creating all kinds of content for oral cavity stuff, nasal cavity stuff. What's the most common things people are going to see? And then about 3.5 years ago, we produced a course where we brought on 7 other APPs, and we filmed a dynamic interactive course, which is a 5.5-hour CE course, where we go over the basics, right? And this was intended for, like I said, the urgent care, primary care world. And so my hopes with this was to, okay, I'm going to be the ENT bridge builder. Let's bring on ortho. Let's bring on urology, fill in the blanks, right? So we did that, and it's been a whole lot of fun. And then, but what's cool about it was, what I didn't expect was my buddy texted me about 1.5 years ago. And he's like, dude, you're on the Connect forum for ENT. And I was like, what are you talking about? He's like, someone was asking about where to train their ENT APPs, and they're referring them to you. And I was like, okay. So I went online on my website or my portal, and I realized that almost half of my course takers were ENT APPs. And so I was like, okay, got it. So we've got something here. So then we started like Facebook messaging, emailing. What's cool about our company is like I said, we want to walk with you, right? And so they have access to me anytime. So like if they email me, if they have a question, they Facebook message me if they have a question. It's been a whole lot of fun. We filmed the ENT course. And then I was like, you know what? The other thing that really bothered me was how often people are doing ear irrigation when they shouldn't be doing ear irrigation. And so I said, look, I learned how to use an operative otoscope when I was a medical student, right? That shouldn't be something restricted just to ENTs, right? We created a cerumen removal course as well, and then a tympanometry course as well, which is ENT stuff.
That's so awesome and so relevant. Like I had a patient yesterday where someone thought maybe they had a ruptured eardrum or something, and they definitely didn't. But like someone, and ears are hard. Like it does take looking at lots of different. Like normal is normal, and I think people are like, okay, that's normal. But then once there's any sort of variation of normal, I think if you haven't gone through it and seen it and learned about it, it's just like, I don't know, it just doesn't look normal. Maybe you should see an ENT.
Actually, 100%. And that's what I tell them. I'm like, look, we're not casting stones. Ears are hard. Like as a practicing ENT with an otology fellowship, I use the tympanometer a couple times a day, right? It's just raising awareness that we don't have this going real well for us, ears in general. And so like, it's just trying to shine a light on a decades old problem.
That's awesome. Congratulations. That's so impactful. It's grown so much. I wanted to go back. So just to kind of how it works. So the course is the actual classroom with the APP participants, the 7 APP participants, and there's probably a back and forth video. So if I'm a learner signing up for it, I'm going to watch that course. It's dynamic and recorded so that you can at least hear the questions they're asking and things like that. And then if I have a separate question, I can reach out to you. Is that sort of...
Yeah, so that was like not intended for ENTs, but that's what we do. And the urgent care folks reach out as well. But what we're doing for ENT as well is we're actually creating kind of like a mini residency where we have live webinars and kind of like Compassio Grand Rounds is what we're calling it, where we partner with other businesses, other ENT practices that are looking to really train up their APPs and to kind of like give them, I'm basically like, I consider myself that I hope I'm the nice program director that we all had, in residency, not the one that we feared. So basically an outlet to come to on a regular basis to invest in them and for them to have a place to come and ask questions.
In training, whether you're a PA or an NP, specialty specific training that's going to happen on the job for most people, right?
Yeah, 100%. 100% actually. And as we know with ENT, that's hard. So like, for that year and a half, I was just basically cherry picking cases that were going to be difficult, that were misdiagnosed. And so I would use those specifically so that when our course takers go and take it, they can review those and know where they might get tripped up. Like we teach them how to use pneumatic otoscopy, how to tell sensorineural hearing loss versus conductive hearing loss. And basically like that first course in the first year of training is basically red flags, common things, what's normal, what's abnormal, and kind of laying that foundation of what a first year resident would know.
And so the course itself, so let's say I have an ENT who has a new APP on board and they've never done ENT before. Let's say they came from primary care setting, for example. How is the course exactly organized? Is it like by ears or is it by like diagnosis or procedures? And how long does it take for somebody to kind of go through it, if you will?
Sure. So it's 5.5 hours of credit. It doesn't take 5.5 hours to get through. I'd say it probably takes about 4 hours to get through, but there's like quizzes and stuff. So basically the way we structured it was, let's start with the absolute basics. Like we're starting like what I learned as a first year resident, like how to even hold an otoscope, right? I was taught right hand, right ear, left hand, so that you can see that anterior, inferior, dip in the proximal ear canal. And then we start there and we start with the general head neck exam, oral cavity or pharynx. What are we looking for? Like, let's not stick the tongue out and say, especially on those obese males, let's let the tongue stay in there and take a deep breath in. Why is this important? Because of human papillomavirus rise of incidence in HPV cancer, right? So we're teaching them a basic head neck exam, just laying the foundation. Like when they finish this course, they should be at the level of like they've been doing this for 6 months at least. You know what I'm saying? And so, and it's all the stuff that even I've learned on the job, that these are things you need to look out for. And these are the red flags, right? And so, but we take them through each system, like oral cavity, oral pharynx. We've got like 7 or 8 common pathologies. And then we talk about them. We talk about how we made the diagnosis and then how we treated it. And we do that for each system, the neck, we do nasal cavity, and then we do ears. And I would say the ears get a lot of attention just because, like we said, ears are hard. And so we basically have like, okay, 7 to 8 HD images and videos. Then, okay, let's do the Valsalva maneuver. That's something I do a lot. First, here's the contraindications. Here's what this video looks like if a patient with a retracted eardrum that you thought was a TM perf, and then when they blow, you can see it come out, right? You don't need a tympanogram on them. Let's use the tuning fork or even the hum test. If you're on the floor and you don't have a tuning fork, yeah, if they've got fluid, it'll go to that right side, or if they hum, it'll go to that right side. Then we go pneumatic otoscopy. My nurse taught me how to film pneumatic otoscopy with a puffer, like an ear puffer that you put. So we simulate pneumatic otoscopy and you can see the eardrum moving, which is super cool. And then we do tympanometry. So it's basically like building upon itself. And we use, as often as possible, we use videos and cases to show them why the patient's feeling the way they're feeling, if that makes sense.
Do they need to take them in a certain order?
Yeah, so it's basically, we start off with ears and then it builds on itself. Then we go over cerumen removal, the outer ear, otitis externa, how to do that. We've got that built up so that we start with the basics, like, okay, let's start with the lateral third, the cartilaginous third. Here's what you should be able to do by week 4. Here's what you should be able to do by week 6. And then, hey, notice the difference between the bony ear canal and the cartilaginous ear canal. You still have 2/3 of the ear canal to go. So if you're blindly going in the cartilaginous portion and just basically turning around, that's okay. Like, don't be afraid of that. And then, but we kind of walk with them and then, okay, here's a senior level thing with suction or curette or alligator forceps. So that it kind of builds upon itself. And then we go over, like I said, the head and neck stuff. The live stuff that we're starting to do is kind of honing in more, and it's taking it to the next level.
What are some of the most common or questions that some of the learners have sent to you on Facebook or that came up in the live, like the video recorded session, and where you're like, oh yeah, we probably need to add another module on this? Because I imagine it's continuing to grow because people will ask you different things.
100%. So I was going to make vertigo its own course, right? And so what I've decided to do is I've decided to tackle that in a live fashion, because people wanted more like symptoms. Like, what I'm not doing is I'm not going, here's 200 diagnoses, memorize them all. I want them to think. So okay, patient comes in with ear pressure. What do you think about that? And they're liking that. Like, okay, yes, did you know that TMD can cause ear pressure, right? So make sure you're checking for that. Eustachian tube dysfunction, obviously, but did you know that endolymphatic high drops can sometimes only present as ear pressure? So I want them to think. And so we're taking symptoms and we're actually teaching them the disease processes through the symptoms. But I want them, when they're talking to the patient, I want them to be thinking of all these things that could be going on.
Yeah, being able to create kind of a broad differential other than just acute otitis media.
Yeah, yes, and it's sad. But to your point earlier, what? And that's just it. It's like laryngosclerosis is the biggest misdiagnosed thing, and it's like, look, this is now they know, and it's funny because our nurse practitioners that took the course with us that work in our ER, they're now considered the experts of the ear and the ER, and so the doctors will go ask them, what is this? And, it doesn't take that much. I think that's what's so cool about this is it doesn't take that much to bridge that gap, a little bit of education and a little bit of follow-up. And it's like, oh, and then there's confidence in actual better diagnostics, so.
When you think about your synchronous versus asynchronous educational modules, you mentioned doing the dizzy patient cases as a live event. How do you think about that as far as when you're making that decision, and what benefits do you have over doing a live event versus a recorded module?
Yeah, great question. I think truth be told, when I started doing this, I was like, hey, this is a way to get it out there and to have some passive income. Let's be honest, right? It was and you don't touch it anymore, right? But what I love is I love to teach. And so it's I love this. I love the interaction. And so I find that even if it's a few students, I'm actually moving more, each specialty we bring on, they're going to have a foundation. Because what I like for the students is they can go back to my cerumen course and they can say, okay, yeah, and then they can go back to my videos of the ears, my nasal endoscopy or flexible laryngoscopy. So they have to have that as like a library, but I find that the interaction is so much better and like the cases that we bring. So everything we do is pretty much symptom case based. And then we build it out from there. Like we might teach them how to read a CT scan from there, or how to read an MRI of the IC from there, how to work up the vertiginous patient. So we're heading in that direction. So it's like a monthly webinar that we're building out, and then just a place for them to in a forum too, on our website, a forum for them to interact and ask questions amongst themselves too.
Yeah, I mean, it creates like a group. I mean, we didn't learn ENT by ourselves, right? Like like we had each other, we had our co-residents, you had residents above you, fellows, you had a lot of different attendees. And so having that dialogue and camaraderie and being, oh yeah, I had that same question too, or oh, try this. Like that's so helpful, right? Like
no, 100%. Like, and that's what's so much fun. Like, I came from two great programs, LSU and UNC, and I think I was one of the few UNC residents to not go into academics, right? And it's kind of funny because now I'm like talking
the most academic person. You're like the most academic of them all now.
It's hilarious. I'm writing journal articles. What am I doing, right? And you know, and so it's kind of like, and I think that was like where my heart is. It's like we all need people. Like we all depended on people, right? Good people. And like no one wants to feel like they were on an island. And how common is it for specialists to reach out to primary care and say, hey, we want to teach you? It's not, you know, like including myself before I started this, right? I mean, I've enjoyed teaching my NPs or whatever, or medical students, but to be able to go like a conference in like to be on a webinar in Denver or Wisconsin or whatever, like that's rewarding. And it's been awesome to have the support of other ENT colleagues to kind of, because I bounce this off of them, like, what do y'all think? And they're like, no, keep going. So I'm grateful.
Yeah. Tell me, how do you teach surgical decision-making, or like, you know, there's a lot of nuanced variability in what we do because so much of what we do is quality of life. It may even be from when to sort of think about repairing like a hole in the eardrum to especially sinus, you know, or allergy things. How is that included or incorporated in the course?
So we're talking like that's high level, right? Like that's like after 6 months of training, of webinars at least, they're at least learning like for pediatrics, you know, these are the guidelines, right? You need to be thinking that when you're evaluating the patient, how long has that serous otitis media been there? Has it been 3 months? You get a hearing test on that patient. Why? Because that's the guidelines. And on average, they have 28 decibels of hearing loss. So you need to get a hearing test to make sure they don't need tubes, right? So we teach them the guidelines like that. But as far as like the more nuanced things, like, well, like thyroids, you know, thyroid ultrasounds, okay? That's kind of something more like, hey, this is black and white as far as like, this is what you need to do. You need to get a fine needle biopsy on this patient. These are the characteristics of the ultrasound that are concerning. The calcifications is the Bethesda score, and going from there. Sinus is a little bit more nuanced. Part of this too is not kind of like having a cookie cutter for each practice. I want to know what the practice themselves, what their pain points are, and what they want their providers to learn. Like what are your pain points? Like, are your providers going to be preparing people for sinus surgery, right? Are your providers like how much autonomy do they have? And so I kind of am tailoring it for each practice. But like sinus surgery, that is something like if you're at a rhinology-based practice, yeah, you need to learn, you know, how many antibiotics, when do you get a CAT scan? And obviously how to scope the patients as well.
Is scoping part of learning on the Compassio curriculum?
It will be. It's not now. And so I think
because it's such a huge part of what we do, and you can record it and talk about it and look at it, and it's a time saver in a way for the patient and for everybody to kind of.
No, I agree. It's so we have all the endoscopy and we have all the flexible laryngoscopy, and we're building more of that because like if I can film it, I do it. And if it's a teaching point, we film it, right? And so we're building all that. We have a lot of that. I think with nasal endoscopy, flexible laryngoscopy, I think that there needs to be more hands-on courses. I know that the ENTPA Society puts on a course, and I've reached out to them. I think that I would love to put on some hands-on courses. And I think too, though, that's where having like colleagues, like we learned as medical students doing it on each other. But I feel like prior to that, they need to learn what is normal, what's abnormal before you start doing it. Does that make sense? And I think too that there's a tendency to rush into that before they're creating the foundation of ENT. Because a lot of these people, they haven't even looked at that many ears to begin with. And so it's like creating that foundation. What are the red flags? What don't I want to miss? And then let's get into more of like a little bit more of the hands-on stuff. Cerumen removal, yeah, that can come earlier on.
Do you work with like multiple APPs in your own practice?
Yes. So I'm glad you asked that. Yes, there's just two, but we have one that's been with me for 10 years. And we just had one that we brought on 6 weeks ago. So basically, I'm like, okay, new person, Ashley, you're going to get the benefit of all of this stuff that I didn't give to Leslie.
And you have Leslie. And you have
Right.
Leslie now. I mean, that's
well,
huge.
No, absolutely. Absolutely. But it's been cool to bounce things off of Leslie as well, like as we're making this journey, right? So we're training them. But I think what I've learned is we're all busy. This takes time. And so that's why I've actually backed off on my practice about 25, 30% to build this content, to invest in them. Like when we did, grand rounds in residency, there was time set apart for that. There were a lot of faculty that we had education half days or whatever to prepare content. So we're doing all of that to basically invest in them. And so, so I'm kind of like, Leslie, I'm sorry, we're going to do better for you. And Ashley, you're going to do well. And so anyway, it's fun. So we're teaching them how to scope now. Ashley, not so much. She's just watching, she's watching me over the shoulder, but she's already taken our course. And then they're actually kind of guiding some of this education as well, kind of helping me make the syllabus.
For the courses, is there like any sort of like handbook or written, like formal, like book or workbook that goes with the material?
So that's something that has been requested of us. And so we're making that. So no, not right now, but that's one of the questions that was asked. Can we please have something to kind of like a little tutorial to walk with? Yeah.
I know, but like just personally as a learner, I'm like very, like I like to also like, I can listen to it and see it, but I also just like the visual reinforcement of like words on a page, or to be able to write on it or highlight it. Or I don't know. There's something about my learning that is solidified when I have like a physical book.
I like to be able to, with a book or article, which I'm not a huge textbook person, because for me, it's just like, there's so much to go through, but I can find it.
Yep.
Like whatever question, I can go back and I know where it is on the page. But sometimes with audio, like a podcast, a lecture, or a video, having to kind of rewind, it's like a timestamp, and I don't always remember, was that the beginning of the talk? And so it's kind of harder for me to go back.
I agree. I'm the same way. I like literally, when I'm on a talk, I'm writing things down. What we did do for the course was we broke it up into like small sections, so that if there's the pneumatic otoscopy section, there's the neck section, there's, you know what I mean? So there's that, but no, we need to have something for them to write down on. So yeah.
For your modules, I know they're like by topic online. And let's say like I purchased a module and I went through that. For the ongoing kind of interactive Facebook group and that part of support, do you do a membership model for that part of it, so that people can kind of continue to engage?
Yep. So basically like online right now, like all in for all the ENT courses, it's going to be about $900 to $1,000. And that's too much. And so what I started to do was, because some people are going to get through this in like 6 weeks, 6 months, so we're going to start doing a subscription model where it's like, $25, $30 a month with access to me, and Courtney, our audiologist, works with me as well. And so she does the hearing test and the tympanometry and stuff like that. So that's kind of an ongoing thing, just to kind of,
Yeah, I think that's a good idea. I like it.
Do you feel that the curriculum, the way it's set up, it sounds like it's very outpatient heavy. Do you find that you have the same number of learners that do primarily inpatient ENT that also are participants?
It's a great question. And yes, so we do go to the bedside in the hospital for some of my patients. Like some of the more common things you're going to see. In fact, one of the cooler videos we do is, this was during COVID. I got our videographer in, and I was like, look, do you mind coming and film this? So it was a patient who had really bad peritonitis. And we just did a video showing us milking the parotid gland, showing the purulence, going into the oral cavity, showing the pus coming out, and doing a culture swab of it. We could use more of that for sure, but we're trying to do it both and. It's basically what anyone in the ER, urgent care, or ENT should know. So it's so that the ER urgent care stuff kind of covers a lot of that. And so, but we can do more, like nosebleeds. Like that's something that we go over a little bit of nosebleeds, but that's going to be its own topic. That's going to be its own lecture.
For sure.
And the algorithm of how to deal with that.
So in terms of your non-ENT learners that take this to get the ENT education, so the urgent care, the ER, what percentage of your participants are like the family practice physician or APP?
Yeah, I would say it's probably close to half. I would say it's 50-50. urgent care ER. We've got some peds, a lot of peds that have taken it, and then the other half being ENT.
And for the listener who is thinking, I'm about to hire a new APP for my practice, like, how do you recommend using this curriculum? I would imagine, you tell me, but I would imagine that pairing this with, in person, just, like dedicated time to kind of discuss the questions that come
Or
up.
like Facebook, Jeff. Here's your course, and then all questions go to Jeff.
Outsource all training
I'll see you
to
Monday.
Jeff. But like, when people ask you like, hey, I've got a new APP coming on, like, how can I utilize your course to kind of help onboard and train my people?
Yeah, I would basically meet with them, have a conversation like this and say, okay, kind of first feel out what their pain points are, tell them what it's going to provide, and then tell them like, what is your goal for your APPs? Like, how much autonomy are they going to have? What are your goals? And then once I find out what their goals are, like I met with a group out of Houston last week, and they're like, we need help with ears. We need hearing loss. We need vertigo. We need otalgia. And then I forget the other one. And I was like, okay, got it. And so basically just tailoring lectures to them. And then after a year, they may say, we're good. Thank you. You know what I mean? But if there's someone that wants more, and it's like, okay, and I am looking forward to collaborating with my colleagues that are like head and neck specialists or, otologists, and saying, hey, would you mind coming on and helping me with a talk, blah, blah, blah. I think I will go as far as there is a need.
That's cool. So they might consult with you first.
Yes.
The practice it sounds like multiple practices are consulting with you first to kind of say, hey, we have this new hire, or we want to train up, or we want to add an education course to our practice. Yep. And then that's neat. That's really cool. And then you can kind of curate it and tailor it.
And that's what's cool about it, because it's like, again, like the online stuff is great, but the more fun stuff is in person and forming relationships and walking with them. And so that's and that, honestly, it's like I see it as like a mini ENT residency that, like, after a year or two, they should be good, confident. And then like, they're not afraid to email me. Or someone emailed me the other day and I got right back to her. She did it through our portal, and she's like, you're taking care of all of these emails. I was like, I'm a startup. I'm like,
I wear all the hats.
Yes. I'm it. So yeah.
That's so great. I was looking through, like, you have a video on your website just with like an example course, kind of like just that flashes pictures of eardrums. And the question is, hole or no hole, fluid or no fluid. And I was like, just sitting there watching it, like, doing my little guess. And, but I'm like, this is so relevant because, you've got the patient that has a deep retraction that kind of looks like a hole if you don't know what you're looking at. And I was like, it's very like straightforward and simple, but like powerful and like a really great resource.
I sought the advice. I got connected with an education mentor, right? Like, who taught school he was like 70 years old, and I met with him. He's like, you have to build on itself, right? And so like, keep repetition, but build on itself, right? And so it's so cool. At the end of the ear portion, we have an ear that I didn't know whether it was fluid or not. And so we walked through it, and I'm like, okay, and one of the NPs was John. I was like, John, okay, on Valsalva maneuver, what are you going to see? He's like, well, if they can clear it, it's going to be bubbles. Okay, on tuning fork, what's it going to be? He's like, Weber to the right, bone conduction greater than air conduction. I'm like, okay, pneumatic otoscopy, no movement. Okay, tympanometry, type B, normal volume. I was like, bam, you got it. Isn't that cool? So it's just like they're just like, yeah, it's a lot of fun. It's a whole lot of fun.
That's cool.
You mentioned kind of moving into other specialties, and I was like looking through some of your other course directors, and some of them share your last name, so I wasn't sure.
I know.
I was like, do they look
alike,
family
not
affair?
Look alike? I was like, but LaCour is not. Maybe it's a comment. It's South Louisiana. I don't know.
Yes. So we've got, my oldest brother is an ophthalmologist. And so he's going to be taking care of optho, and he likes the camera. So my other brother is Steve. He's a urologist, and not as much does he like the camera. But and then we have an awesome EKG course that we put out. That's one of my colleagues at my hospital. He's awesome, and it's just neat. Like, he trained at LSU when I was there early on in residency. And like, his EKG course is basically a replica of what he did 20 years ago. That's just been building upon itself. So it's really neat. He loves also the fact that he's able to get it out to everybody.
So 5-year plan, 10-year plan, or is this going to be like beyond ENT, lots of specialties, lots of
That's the hope, Ashley. Like, I mean, that was the initial, I've been humbled by this as well. I mean, like I was very naive. I was like, this is going to come out. We're just going to boom, we're going to skyrocket. I was like, no, humble pie. Welcome to reality, buddy. And so that's been good for my ego as well. And so, but just in general, like, I think that that's the hope realistically, like just with the capital that it's taken to get to this point. It's like, ENT, I'm an ENT. We're going to go all in for this. Once we really prove the concept, then yeah, let's go to cardiology. Let's go to ophtho, because that's a real big need. Let's go to orthopedics. I've got 2 orthopedic docs that are collecting content, waiting to do this. But I think the model is going to be a baseline online course first as like a foundation, and then access. So it takes like-minded people too. It takes people that are willing to alter their practice, honestly, because this is a lot on a family to give in this much time. So thankfully, my wife is super patient.
She sounds like a saint. 7 children. And you're off doing this little side hustle thing.
It was so funny, y'all. She came in when I was filming, and I was like, loving, doing all this stuff. And she's like, oh gosh, he loves this. She's like, this is not good. And so, but she's been so good because but she's also walked through it and has been patient. It's like, okay, we're going to give it 6 more months. We're going to give it 1 more year. And it's like, but I think that's been the beauty of it too, because as physicians, we're used to people doing what we ask them to do. We're used to people, and it's like, and getting into the real world of like sales and entrepreneurship, like this is hard, but it's awesome. Like it's made me more appreciative and also more empathetic to drug reps and, that are coming in trying to sell stuff. So it's been an awesome journey.
She's your Compassio.
Yes,
we all have our Compassio.
100%. 100%. Yes.
My last question was, I know you had mentioned other applications of this education, and you mentioned the antibiotic stewardship program. So tell us a little bit of how this education content has also it sounds like maybe a quality improvement endeavor or...
So as we talked about a ton, ears are misdiagnosed a ton, and people are getting antibiotics. I mean, I've got patients that are put on 5 or 6 antibiotics a year for acute otitis media, and they've never had one ear infection, some of whom have had C. diff, right? So what I've been doing, I partner with Mako Diagnostics with their Easy Temp. And so what they will do, and honestly, I'm even encouraging this for APPs and ENT, to get a tympanometer, like a portable one, so you don't have to disrupt the flow of audiology. And you can check yourself with a tympanometer when you're at the bedside with the patient, right? When you're in the patient room. So, but we're onboarding urgent cares, hospital systems for an outpatient deal where we onboard them with the tympanometry course, the ENT course, and then just like this, we provide live talks on things that they're going to see that are often misdiagnosed. So I did one yesterday for Denver Health in Colorado. Basically, like we went over like dizziness, hearing loss, or a child with tubes. You can't have an ear infection if there's not drainage unless the tube is clogged, right? And a type B large volume will show you that. So we're actually collaborating with Mako and onboarding them with tympanometry. We're teaching them how to do it. Our audiologist is helping. And then we're giving them this antibiotic stewardship program. And we're doing a research project right now in Denver showing, did this change your diagnoses? Did this patient get an antibiotic? And I mean, I think we all know what's going to happen with that. It's like, this is so cool because, again, not a big ask. I mean, it's actually revenue generating. Like, each tympanometer is going to equal about 20 to 25K a year per provider. It's going to give them confidence to say, actually, this isn't an infection. I know you're having ear pain, but we teach them about TMD. And then look, this type A tip shows that you don't have any fluid. So that's going to increase patient satisfaction, not getting an antibiotic, because they might be upset not getting an antibiotic. But we're actually giving them the right diagnosis.
Amazing. Professor LaCour.
Who'd have thought, right? My ENT colleagues at UNC are going to be laughing, but it was great. Like when I was at UNC, like to get into UNC, you have to have like 20 articles. That's not actual, but it seems like they are like 20 articles, and I had like 1. And I was like, all right, there we go. Dr. Pillsbury actually asked me, he's like, why didn't I see you on the interview trail? I was like, y'all might have laughed at my application.
I may not have the invitation, yeah.
Yeah, you that was quickly looked over. Yeah.
We all hit our academic stride, peaks at different times in our lives,
Hilarious.
That's
So good.
awesome. Well, this is so exciting, Jeff. This is really cool. If anybody has any questions for you or, wants to learn more about Compassio or, hey, can I have a phone call or chat with you? Like I'm hired or building out, we want to incorporate new education. How do they reach out to you? Are you on social media or?
Yep. You can look me up. I'm on Facebook, Instagram, TikTok, LinkedIn. LinkedIn's our biggest presence. You can look at our website, CompassioMedical.com. It's basically compassion without the N, CompassioMedical.com. And then you can email me directly through there. I'm happy to chat and I'm happy to be available.
Thanks so much for taking the time.
Thank you guys. It's
awesome.
a pleasure.
I'm so excited to see how your company grows and takes off in the next several years. It's going to be great.
Awesome. Thanks, Gopi. I really appreciate y'all. Thanks for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor's Version Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.